Good morning, all. Today, our topic of discussion is root canal obturation. This question has been, that is, this chapter. You can expect a question from this chapter for your who has university exams for part 2 BDS. This has been asked like classify obturation techniques, and you will be asked to write in detail about one of the techniques. This has been asked in previous years. You get a lot of short notes also from this chapter. So let us move on to the details. Coming to the definition of obturation. Obturation is defined as a three-dimensional filling of the entire root canal system as close to the cemento-dentinal junction or the CDJ so as to obtain an impermeable seal at the apex. So we can understand this like obturation is defined as a three-dimensional filling of the entire root canal system. After doing the thorough cleaning and shaping of the root canal system, and after ensuring that it is the complete disinfection process has been completed. So this process makes sure that there is a complete three-dimensional filling of the entire root canal space till the cemento-dentinal junction, because this cemento-dentinal junction for the CDJ is considered as the most reliable point or the most reliable structure for doing an obturation. Now, successful endodontic treatment depends on the following facts. The first one is proper diagnosis of the condition and favorable prognosis assessment, then proper disinfection, cleaning, and shaping of the root canals, which is followed by obturation of the root canal. So all these factors plays very important role in the successful endodontic treatment. Why to obturate the canal? So what's the purpose of doing an obturation? So just like our primary goal for root canal treatment is to make the root canal space completely devoid of any infectious organisms or any infections and microbes, and filling of this canal so that it does not again does not get a entry, or it does not provide a entry for further microbes or pathogens for causing an infection. So these are the reasons for doing the obturation procedure. First of all, to stop coronal leakage. After completion of your root canal treatment, there should not be any coronal leakage into the root canal space. The second one is to entomb surviving microbes. And the third one is to block influx of water and nutrients. So ideally, it must be capable of providing a barrier for any entry of influx of water or nutrients at the apical portion of the root canal also. So these are the main reasons for obturating root canals. Now the question is about when we can say that a root canal is ready for obturation, or the readiness of the root canal for filling. So these are the criteria. The tooth must be asymptomatic. First of all, the tooth to obturate should be completely asymptomatic. It should be free of any pain or inflammation or any infectious process. It should be totally asymptomatic. Secondly, the canal is cleaned and shaped to optimum size. Your cleaning and shaping procedure should be such a way that it should provide a space for adequate obturation, ensuring a complete blockage for any further microbial entry. And the temporary dressing and medicament must be intact. The temporary dressing and medicament must be intact. This is also a criteria for readiness of the root canal for filling. The negative culture. When you take a culture from the root canal space just prior to your obturation procedure, it should we got to make sure that it is completely devoid of any organisms, microbes. Then no excessive exudate from the canal. There should not be any exudate coming from the canal. This is also a criteria for making sure that our root canal space is ready for obturation. Then there should not be any foul odor coming from the root canal space, and lack of periapical sensitivity. So these are the main criteria or the points to keep in mind just before making sure our root canal system is ready for obturation. Now, the requirements of an ideal root canal filling material. So what are the requirements for an ideal root canal filling material? It should be easily introduced into the canal. That's the first criteria. It should be easily introduced into the root canal space, and it should be radio opaque. Any material which you are going to use for the obturation purpose should be radio opaque, so that the extensions of your obturation or any area, if you want to visualize through a radiograph, should be visible through a radiograph, or should be radio opaque. And the material should be dimensionally stable. The next point is it seals the canal laterally and apically, conforming to its complexity and internal anatomy. An ideal material should seal the canal laterally and apically, conforming to its complex internal anatomy. And the material should be impervious to moisture. And also it should inhibit bacterial growth, and it should be non-irritating to the periapical tissues. It should be sterile or can be easily sterilized. It does not discolor tooth structure. It should not discolor the tooth structure, and it should be easily removed from the canal if necessary. If you attempt for a retreatment later on, it should be able to be removed easily. So these are the requirements for an ideal root canal filling material. Now, materials used for obturation. These are the materials that has been tried and in practice for obturation. Gutta-percha. This is the most commonly used material nowadays for the obturation purpose. Silver cones. This has been in practice few decades before. And Rasilon epiphany system. Then MTA. So these are the major materials used for the obturation. Now let us go into the details. The first one is gutta-percha. Gutta meaning gum, whereas percha is the name of the tree in Malay language. So this was first introduced to dentistry as a temporary filling material by Edwin Truman. Now let us look into the chemistry of gutta-percha. Gutta-percha is a trans isomer of polyisoprene. It is harder, more brittle, and less elastic than the natural rubber. When you look at the composition of gutta-percha, the major composition goes for zinc oxide, 59 to 76%, whereas gutta-percha constitutes about 18 to 20%. Radio opacifiers 1 to 18%, and plasticizers 1 to 4%. So this is the composition of gutta-percha. Now, gutta-percha exists in two crystalline forms, alpha form and beta form. The alpha form is pliable, tacky at 56 to 64 degrees centigrade, and is available in the form of balls and pellets. This form is also used in thermoplasticized technique, whereas the beta form is rigid and solid at 42 to 44 degrees centigrade. It is used in the manufacture of gutta-percha sticks and points. So this beta form is used in for the manufacture of gutta-percha sticks and points. So you can see that the beta form, which is at a temperature of 42 to 44 degrees centigrade, when it is heated, it is converted to alpha form at 56 to 64 degrees centigrade, which is pliable and tacky. Again, when it is heated, it is converted into, when it is heated to higher temperature, it is converted into amorphous form. Now coming to the advantages of gutta-percha. First one is its compactability. You can easily compact it to fill up the spaces of the root canal, and its inertness, then its dimensional stability, and its tissue tolerance, and its radio opacity. Then it becomes plastic when warm, and non-solvents. So these are the solvents available for gutta-percha: chloroform, cyanide, eucalyptus oil, etc. So this becomes easily soluble in these products, and it can be sterilized in 5.25% sodium hypochlorite for 1 minute. So you have to note that this is a method for sterilization of gutta-percha. You can immerse it in 5.25% sodium hypochlorite for 1 minute for sterilizing it. Coming to the disadvantages of gutta-percha, it lack lack of rigidity, lack adhesive property, and easily displaced under pressure. These are the available forms of gutta-percha. You can see in the images here: gutta-percha points, auxiliary points. So gutta-percha points are available in standardized form and sizes. Then auxiliary points, which are non-standardized. Then greater taper gutta-percha points, gutta-percha pellets or balls, then core carrier gutta-percha, then syringe system, then gutta flow, which is a flowable, cold flowable material, then medicated gutta-percha. So these are the available forms of gutta-percha. I will repeat: gutta-percha points, auxiliary points, greater taper GP points, GP pellets or balls, core carrier GP, which is to be used with the core carrier system, then syringe system, then gutta flow is a cold flowable material, and medicated gutta-percha. Now coming to the next material, obturation material, silver cones. In 1933, Jasper introduced these silver cones. Their rigidity made them easy to place into the root canals. However, their inability to fill the irregularly shaped root canal system permitted leakage. So you can see that these silver cones were rigid enough to be easily introduced into the root canal space. But the drawback was that their inability to fill the irregularly shaped root canal system, which causes further leakage. And other disadvantages are inability to fill the, which is already we have explained, irregularly shaped root canals, and hence leakage. Then when in contact with tissue fluids or saliva, they corrode. So these silver cones tend to corrode within the root canal space when it comes in contact with tissue fluids or saliva. Corrosion products are cytotoxic and produce pathosis or impeded periapical healing. So these were the main drawbacks of silver cones. Now coming to the obturation techniques. So the obturation techniques are classified according to Engel as solid core gutta-percha with sealants, under which you have cold gutta-percha points. That is a lateral compaction technique. Next is chemically plasticized cold gutta-percha, where you have essential oils and solvents like eucalyptol, chloroform, and halothane. Then canal warmed gutta-percha, under which you have vertical compaction, system B compaction, sectional compaction, lateral or vertical compaction, thermomechanical compaction, under which you have Max-Padden compactor, ultrasonic plasticizing method. Then thermoplasticized gutta-percha obturation techniques. That is, again you have syringe insertion method, under which obtura, inject, R-fill, and backfill are available. Then solid core carrier insertion, under which you have thermofill, success fill, and simply. Then the second category, apical third filling, under which you have dentin chip filling, calcium hydroxide, and light speed simply fill method. Then injection or spiral filling, under which is done with cements, paste, plastics, or calcium phosphate. Then the obturation methods have been classified according to Cohen as the cold compaction of gutta percha, the compaction of gutta percha that has been heat softened and then cold compacted. The compaction of gutta percha that has been thermoplasticized, injected in canal and then cold compacted. The compaction of gutta percha that has been placed in the canal and softened by mechanical means. So this classification I have taken from Grossman 13th edition. Techniques of obturation has been classified according to Grossman into 8 category. First one is cold lateral compaction. Second one is warm compaction with warm gutta percha, under which you have vertical compaction and lateral compaction. Then the third one is continuous wave compaction technique. The fourth one is thermoplasticized gutta percha injection method. The fifth one is carrier based gutta percha techniques, under which the thermophil thermoplasticized technique and simplified sectional obturation techniques are coming. Under sixth heading, Max-Padden thermomechanical compaction. Then the seventh is chemically plasticized gutta percha, and the eighth is custom cone obturation technique. Now let's move into the details of these techniques. The first one is lateral compaction of gutta percha. Is one of the most commonly employed techniques by the clinicians. The objective is to fill the canal with gutta percha points or cones by compacting them laterally against the sides of the root canal walls. Two main types of spreader instruments are available: long handle spreaders, then finger spreaders. You can see it in the images. The first one is the finger spreader, as the next is the long handle hand spreaders. Finger spreaders provide better tactile sensation and less likely to induce fractures during the lateral compaction technique. Now about the spreader considerations. This again have taken from Grossman textbook. The size of the spreader is determined by the width of the prepared canal and the lateral fit of the primary cone. It says that the size of the spreader is determined by the width of the prepared canal and the lateral fit of the primary cone. The greater the space between the canal wall and the butt end of the gutta percha, the larger or wider the spreader used should be. The spreader size should reach within 1 to 2 millimeters of the working length in order to obtain optimal apical compaction. This can be ensured by placing a silicon stopper on the spreader. So the idea is that the spreader selected should reach within 1 to 2 millimeters of the working length in order to obtain optimal apical compaction. Then about master cone consideration. Selection of the master cone should be similar to that of the master apical file size. Master apical file is the file which is used for the last file for the largest file. The largest file used for your apical preparation. So you have to select the master cone according to size of your master apical file size. Minimal judicious force should be used onto the spreader during the compaction process in order to avoid root fractures. Now about spreader fit, as I told you earlier, it should fit within 1 to 2 millimeters of the correct working length. If not, more shaping is required because apical size and taper is inadequate. So your apical size and taper should be adequate for this fitting of your spreader, that is so as to reach 1 to 2 millimeters of the working length. Excessive force should be avoided. Cold gutta percha is not greatly compressible, and as little as 1.5 kilogram of pressure are capable of fracturing the root. So this is one of the drawback of this technique. When more or greater force is applied than the permitted, that is more than 1.5 kilogram of pressure is applied, this causes root fracture. Now about master cone fit. The master cone selected should be corresponds to the size of your master apical file. For example, master apical file size is, if it is 30, master cone size should also be 30. These are images showing placement of master cone. So in the following diagrams, the lateral compaction obturation techniques is explained. First of all, select the master cone corresponding to the master apical file. check the master cone for its correct length, working length, so as and make a mark on the coronal part of its end with the reference point of the tooth. And if the master cone fits that full working length, you are ready to obturate. Mark the master cone to the full working length on its coronal and place master cone in the canal system. Master cone fit is checked by taking a radiograph. Then the master cone should have a definite apical resistance when master cone is placed to full working length. So this resistance to removal of the master cone is said to be is known as tuck back or resistance for the removal. While attempting to remove the master cone is known as tuck back. Then the root canal sealer is mixed at the correct consistency, and the sealer is applied into the root canal walls using a Lendello spiral or with a reamer. Then coat the master gutta-percha cone with the sealer and place it into the correct full working length. Then use a correct spreader size so as to reach 1 to 2 millimeter from the working length. Then compact the master cone laterally. Then the next accessory cone is placed and the procedure is repeated, again compacting laterally. And the process is continued till no more accessory cone is able to be inserted into the canal until the canal is so this process is continued until the canal is obturated to the cervical line. Take a radiograph at this time and evaluate the fill of the canal. Then this confirms adequacy of the obturation. If the obturation is satisfactory, the excess gutta-percha cone should be cut to the CEJ level, buccolingually. If obturation is not dense or if voids are present, remove all the cones and redo the obturation process. So this is the image. Just cut off the coronal butt end of the gutta-percha cones. Then condense it. Clean the coronal part of the orifice. Clear away the sealer particles. Then a final radiograph is taken. Remove the rubber dam clamp and rubber dam material and take the radiograph. Usually, you have to note that usually a temporary restoration is placed before the rubber dam is removed. So again, I'm just going into the summary of this lateral condensation technique.